I still remember my worst moment as a doctor. As my patient walked out of the consulting room, I had a nagging doubt that something just wasn't quite right. I didn't expect 3 hours later he'd dropped down dead, leaving behind a wife and small children. Putting the phone down on the grim news, I was in a state of shock that rapidly gave way to an overwhelming sense of panic. Grabbing his notes, I frantically relived the consultation again and again. What had I missed? Will others blame me? Will I get sued? Could I lose my job? General practitioners are more likely than ever before to receive a claim of negligence. In the UK NHS in 2021-22, 15,000 new claims were settled at a cost of £2.6 billion. A survey of 600 GPs by the UK Medical Protection Society revealed that 67% of those responding feared being sued by their patients. And of those, 85% felt that fear impacted on the way they practiced medicine. 35% had already been sued in the past, with a range of impacts on them. I think there are 5 things you need to do to avoid joining those statistics. In over 30 years working as a general practitioner, I have never been sued. When I was growing up, I always wanted to be an airline pilot. There's a tough selection process, intense studying with exams and practicals to pass, in fact, much like medicine. But as you slide into that seat to take control of a plane full of passengers, you suddenly realise I am responsible for all these lives. And despite my best efforts, we could all die. The first and only 100% successful way to not get sued is give up medicine. Don't get on that plane. If you're so fearful of a patient suing you, then perhaps you're in the wrong job. Can you imagine an airline pilot with a fear of flying? I mean, that doesn't mean to say you go flying around with your eyes closed, your fingers in your ears and going la 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 and hoping for the best. Training to become a general practitioner for me involved working in different hospital jobs to gain a range of experiences. Whatever job I was in, one particular local GP would come up in our conversation. His patients referred into hospital were legendary, and not necessarily in a good way. Every chest pain was a heart attack, even when it was an obvious simple muscle sprain. Every mild stomachache became an ectopic pregnancy or a bursting aortic aneurysm, and every headache was a possible stroke. We wondered at times if he was actually medically qualified. Now, I don't believe in karma, but guess who became my GP when I ended up buying a house locally? That's right. I asked our new neighbours what they thought of him. The best GP we've ever had, was their unanimous verdict. What? How could this be? By then, I'd already had a couple of letters of complaints from patients. Nothing serious, but they were a wake-up call. Was he doing something right that I was doing wrong? I think it's a bit like this. We all sit somewhere in this graph as doctors and clinicians. Clinical care is applying up-to-date medical knowledge to the patient's problem. Personalised care is walking with your patient to guide them as safely as possible through that care. This needs good continuity of care and good people skills. Studies show when we enter medical school, most of us start here. However, there is a tendency for this as we go through our medical training, and we lose the ability to empathise and the ability to recognise and respond to our patients' true needs. I think my own personal low point was when I wished a patient would die so I could go to sleep. And as I had that thought, I realised something just wasn't quite right. Listening to my neighbours, I realised why they loved their GP so much. If one of their children was ill, he often popped in on his way home to check that they were recovering. He was quick to phone patients to give them results from important x-rays and blood tests, knowing they would be worried. He was a good listener and showed interest in them as people and their lives. He replied quickly to their messages and concerns, and yes, if they were ill, he was quick to refer them to hospital, just to be sure. And I found myself asking this question: who is the better GP, him or me? Which of these is more important? It's a bit like asking which wing is more important for this plane to fly safely. I think the second thing you need to do to avoid being sued is focusing on making sure both wings are strong and responsive to prevailing conditions. Have you ever been on an aeroplane and the pilot comes over the tannoy? Ladies and gentlemen, we are approaching some turbulence. Please return to your seats, stow your tray in the upright position and fasten your seatbelts. It's the pilot's job to scan ahead using their equipment and training, looking for potential problems and navigating their patients safely through any turbulence. I use a mental traffic light system with each of my patients as they walk out of my consulting room. Green: my medical radar isn't flashing any warning signs. I've no concerns, and my patient's behaviour suggests that they were happy with my care. The vast majority of patient contacts are like this, and low risk, normal operating conditions. Orange, potential dangers ahead. Up your concentration and focus. Airline pilots have standard operating procedures to ensure safety at all times. Why not develop your own medical standard operating procedures? My response improves continuity of care, avoiding patients bouncing around from doctor to doctor. Any change in their condition is quickly identified and new routes plotted without delay. In this, I think a diary is essential. The weakest pen is stronger than the strongest memory. Seeing the same doctor improves patient outcomes, reduces their risk of dying in one study by 25%. Patient satisfaction increases, and so will your enjoyment in the job. And consequently, it reduces your risk of being sued. Therefore, the third thing I think you need to do to avoid being sued is learn to recognise risky situations and increase your personalised patient care with increased continuity of care for your patient. Traffic light red. An engine has failed. This plane is going down one way or another. On the 15th of January 2009, US Airways Flight 1549 suffered a double bird strike, taking out both engines and turning the Airbus A320 into a glider with 155 passengers on board. It's every pilot's worst nightmare. What happened next was called The Miracle on the Hudson and made into a film named after the captain. A red medical event would be my patient coming to a serious unexpected harm, or an unnecessary delay in an important diagnosis, or unexpectedly dropping dead after leaving your consulting room. How you respond now is critical to the outcome. You could go into denial. Do the proverbial ostrich head in the sand. Francesco Schettino in 2012 was captain of the cruise ship Costa Concordia. After hitting some rocks, the ship started to sink. Rather than tend to his needs of his passengers, he somehow fell into a lifeboat and went home, abandoning his passengers to their fate. 32 people died. Looking back, early on in my career, this is how I responded when a red medical event happened. Denial is dangerous for you and your patients. When Captain Sully realised he had no engines, in a video, he explains his initial thoughts. First, this can't be happening. Then, this can't be happening to me. And then realisation dawned. He focused on putting his training and experience into action for his passengers. His one thought wasn't of himself, but of his passengers and how to deliver them safely to their families. When patients come to harm and you're involved, your primary and overriding first thought should be your patient's welfare, or if they've died, that of their families. This is my fourth thing you need to do to avoid being sued. I call it doing a Sully. Of course, there is another possibility in response to a red event: make excuses. That is, to blame the patient and protect your own ego. Don't ever do this, please. Most bad outcomes in medicine are a series of unfortunate events and not just attributed to one individual or cause. After a red event, even after all these years, I lose sleep, get depressed, and I get miserable. I tell my wife, I'm no good. I can't do this job anymore. I've decided this is normal and a correct initial emotional response. I worry about doctors who don't feel like that. Talk to colleagues and seek the support of others, even if you've made a serious mistake. When Sully was a young pilot, he was given this instruction by his flying instructor. A pilot never stops acquiring knowledge. You will make mistakes. Everyone does. Just learn from them. Over the years, I've found I'm most vulnerable to making a mistake when I'm tired, at the end of a long shift, or it's my last patient and my mind is already halfway home, or I'm ill and really I shouldn't be at work. For Captain Sully, there was a public inquiry. Every decision he made over those 208 seconds from no engines to landing in the Hudson was explored, analysed and questioned. Was he right to ditch in the Hudson? Could he have made it to a runway? That inquiry suggested 34 recommendations for change. No one died on Flight 1549 by some miracle. It was a near miss. The fifth thing you need to do to avoid being sued is being willing to learn from any near misses, whether they are big or small. What did I do when my patient dropped down dead unexpectedly 3 hours after having seen me? After my initial panic and fear, my thoughts turned to his wife and family. What I was feeling was nothing compared to what they were now experiencing. They were my patients now. What could I do for them in this situation? There and then I called his wife, offering to meet and answer questions. And it was that evening I found myself driving to their house with his notes in my hands, my stomach wanting to lose its contents as I entered a room packed, and I mean packed, with people, and sat down to explain as best I could what had happened. As I finished and asked for questions, you could have heard a pin drop. Then one of his relatives spoke up. I told him his lifestyle was going to kill him. The tension broke and a much needed discussion was then had. Later, reviewing his notes, I concluded his death was a culmination of a series of causes and I just happened to be the clinician at the end. On a YouTube channel devoted to teaching primary care dermoscopy, why this video and how to avoid being sued? It's best explained with an example. This gentleman in his 60s comes to see you with a 3-month history of this irritating 12mm patch on his left palm. He says it varies in size and Germaline antiseptic cream from the chemist wasn't fully healing it. Could he have a stronger cream, please? What is it? What would you do? It looks a bit like a patch of eczema or a small fungal infection, doesn't it? I could imagine many doctors giving a steroid or antifungal cream with instructions to return if it doesn't heal, right? The non-polarized view shows a well-demarcated lesion, a white homogeneous central mass and peripheral vessels, some dots, some hairpin types with a surface scale. But what's this light brown pigment here? Switching to the polarized light setting had me gasping. A shimmering iridescent blue-white sheen reflected off the surface. This is a melanoma, 3.8mm Breslow thickness at presentation. It has a roughly 50-50% chance of it killing him in the next 5 years. Now imagine if he'd bounced back and forth to your clinic rather than being referred at first presentation. No cream is going to heal this. It's easy to imagine a delay of a few weeks or even months until a doctor suddenly realises something isn't right and refers him. How would that patient feel about your delay in his diagnosis? Could he blame you and sue you for his poorer prognosis? The most common reason for a GP in the UK to be sued is a delay in the diagnosis of cancer. That's why I love dermoscopy. It helps me treat my patients in many ways and reduces my risk of facing a complaint or being sued. To begin your journey into dermoscopy, perhaps start with one of these 2 videos explaining how dermoscopy works. And this video uses 2 stories to explain how to avoid missing a melanoma using dermoscopy.